It's my great honor to introduce my friend and colleague, Isador Lieberman. Dr. Lieberman was with us last night. He flew in from Texas, gave a terrific journal club. We went through four of his articles, and what was just so remarkable is the spectrum of things that we covered, from spinal deformity to pediatric additions to international health. And that spectrum is going to be represented in his talk today as well. Dr. Lieberman's been a real leader in the field of orthopedic spine surgery. He trained in Toronto, and I had the pleasure of first meeting Izzy when I was a medical student. I happened to be at Oxford, and Izzy was a fellow at Nottingham, and he was doing a spine fellowship there. Went back and joined the faculty at Toronto, and moved from there to Cleveland Clinic, where he became the chairman of orthopedics in the Cleveland, Florida program, but also worked in the Ohio program. And finally was recruited to TBI, and he's now in his 13th year at the Texas Back Institute. And I've had a chance to be the visiting professor there. And what a terrific program they've got with gait analysis and research infrastructure. And Lizzie's really led a lot of that academic productivity as well as clinical work. So today, Izzy's going to be with us to talk about two, again, disparate topics that really reflect the breadth of his research and clinical endeavors. He's going to talk about cervical fixation, and really his expertise has been in navigation and robotics. He's also going to share with us some of his experience with international health at Uganda. So, Izzy, thanks for being with us today.
Thank you, partner. Well, it's an absolute honor and privilege to be here, to be invited here. It's great meeting new people and growing the network. I understand there's 40 odd people on Zoom, so now I'm really nervous, and I hope I don't embarrass myself out there. But as Sig had mentioned, I'm going to talk about two things, and this is kind of a contrast of extremes. I'm going from high-tech cervical pedicle screws to treating patients, the less fortunate in Uganda. So just in the spirit of things, these are my disclosures. I do have relationships with each of these entities out there, none of which really impacts what I'm going to be talking about today. Robotics and navigation. This has really allowed us to go where we have not been able to go before. It's been quite remarkable to see what's gone on. I've been involved with this from 2000 to today. There was a lot of skepticism at first. Yeah, when we started out with this technology, it looked like a bad video game. It was just not prime time, but now it is prime time. And what's most exciting to me is seeing all the young people thinking about this and adopting it to make it better for your patients. But the robotics and navigation has really allowed us to step beyond what we've been doing traditionally and go into areas like the cervical spine. So cervical pedicle screws has been something that we just have not used consistently. It's difficult anatomy, it's difficult exposure, there's substantial neurologic risk. But early on, and these were two papers, one was John Heller's paper that looked at the anatomic feasibility and the biomechanical comparison, and they showed that the pullout strength of cervical pedicle screws was substantially higher. And then the second paper showed that the fatigue analysis, the toggle strength and residual pullout was higher for pedicle screws. So we knew that that piece of bone is a good piece of bone. We just had to figure out how to capture it. And here's just a graphic representation showing, yeah, the substantial differences in pullout. And anyone who does any kind of cervical instrumentation knows you're never quite happy with lateral mass screws, and you don't want to have to pass sublaminar wires and hooks. So we do need something else. So cervical pedicle screws were not really the gold standard, the mainstay. We know it provides much more rigid fixation. It can help save the number of levels that you need to address because of better fixation. But there are dangers there. There's the nerve and the vertebral artery. Now you'll see I've crossed out spinal cord. And this took me a little while. I'm a little slow. It takes me a few years to figure things out. But if you look at it, that's where your spinal cord and the thecal sac is. And if you see where the starting point for the screws are, it's well below the equator of that. So the risk of hitting the spinal cord is exceptionally, exceptionally small, unless, of course, you're a three-dimensional moron and you're putting the screws in perpendicular to it. But everyone's worried about that risk, but it's really not a risk. And if you think historically what we've been doing, we've been passing hooks and wires through the cervical epidural space for years without even worrying about that. So it's not really the spinal cord, but the vertebral artery and the nerves are definitely a big issue. Now, when you look at pedicle screw fixation, the pedicle diameter is very small, obviously. There's a much higher convergence angle. So the pedicles are really converging at a very steep angle compared to the thoracic spine or lumbar spine. And God bless Texas. Everybody there is big. SIG is not a big guy in Texas. Some of our patients are mad, and those big necks, you really can't get through it. And I'm going to talk a little bit about preoperative planning for this, but you have to come into that prepared and recognize that that convergence angle is an issue for you. The foramen is a much smaller foramen, so you do not have a lot of leeway there. And the cervical nerve roots anatomically lie different than the lumbar and thoracic nerve roots. So they're closer to the caudal pedicle than they are to the cephalad pedicle at each level. So a superior breach is far more problematic than an inferior breach in the pedicle. And the nerve root angles, the nerve roots exit at a higher acute angle. So anything that comes close to that dorsal root ganglion in the cervical spine is going to be problematic. So you've got to keep all that in mind. Now, we know from anatomic studies that the cervical pedicle is about 3.5 millimeters. 98% of them are about that size. The pedicle width is very small, but doesn't get beyond that 4 millimeter. They're sort of elliptical or triangular in shape. But this is an important thing to remember here, that the medial wall is thicker than the lateral wall. Now, you think, okay, great, it's going to protect the nerves. But lateral, that's where your vertebral artery is. So the lateral skives here are where the problem is. And if you put the screw in and it's bouncing off the side, you're going right into that vertebral artery. Now, the way we used to do this is through an open operation where we'd create this little laminotomy. We'd gently reflect or retract the thecal sac, identify the disc level, move laterally, feel the pedicle with some kind of probe, and then aim your awl or burr or something down there and pray that you don't deviate one way or another, because it's really hard to maintain this convergence angle that you see here with that. And this is where navigation, robotics, and now some of the augmented reality can really help us get these screws in the right spot the first time to optimize the fixation. So we know that biomechanically they're better, but the complex anatomy and the risks is what's held us back up until now. So this is a study that we embarked on to look at my experience with cervical pedicle screws. This was a retrospective review of those that I did with robotic guidance. We took the post-op CT scan, fused it to the preoperative CT scan, and that's how we did the analysis, looking at different points on the screw at the entry point, at the midpoint, and at the distal point of the screw, what the deviations were. And then we obviously went through the chart looking for other technical issues. So this is how we did the analysis. And you can see here's two different levels where we laid the yellow lines here represent my preoperative plan. And you can see where the screws ended up. And then we just measured and calculated the deviations. So this was our first 10 patients that we did. It's the typical cervical group: spondylosis, post-laminectomy issues, fractures and dislocations. One was a tumor patient. We had no intraoperative complications related to the placement of the screws. The robotic guidance was successful in all 78 screws. The postoperative CT scan, 10 pedicle screw breaches. All the breaches were medial and less than 1 millimeter. So again, going back to that first slide I showed, below the equator of the spine, it's very analogous to a sublaminar wire or placing a hook in there. And I'm not in the foramen and I'm not in the vertebral artery. So here's the levels, and you can see which are the screws. What's interesting here is if you look C2, C3, C4, that's where the majority of the breaches were. But C6 and C7, we didn't have any breaches there. And again, it's as the anatomy changes, you've got more real estate to work with. So obviously, it's easier. And here were the deviations, about 1 millimeter in the axial plane and sagittal plane on both sides, with a pretty high standard deviation there. So it's really not too bad when you look at it. And we had no clinically significant issues related to it. So this is sort of my model case. This is the 51-year young female. She had a drop head syndrome. She just could not hold her head up. Her muscles were all atrophied. And you can see the extent of the stenosis that she had there. And this was the other interesting thing. Look at her jugular vein here. This was just a massive jugular vein. I don't know why, but that's what we were dealing with. But this is someone that I wanted to decompress first and hold her up and then decide, do I need to do anything else for her? So here is the preoperative plan. And over the number of years that I've been in robotics and navigation and now with the AR work, I've really appreciated the single most important lesson is the value of coming to the operating room prepared with your preoperative plan. If you were about to go on an airplane and you heard that the pilot didn't do his pre-flight plan, doesn't know how much fuel he has on board, doesn't know how many passengers or the payload or the weight of the plane or what the weather is up ahead, would you go on that plane with him? No, no one would dare. But yet patients are coming to us and we're operating on them without a set plan. We throw up an X-ray and we say, okay, I'll do this, 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 this. And it never really happens that way in the operating room. But when you come with a plan, you're able to facilitate that plan. And yes, sometimes you have to call the audible. Sometimes you change that plan. But at least you've thought about plan A, plan B, and plan C. So this is my pre-op plan. And you can see in my pre-op plans, I typically plan more than I intend to do. If I have to call the audible, we're ready to go with it. And this is looking at it, and you can see how tight the anatomy is here. You've got very little leeway with it. So here's the intraoperative pictures. We've got all the screws in place using the robot, and here's the post-op result with it. Here you can see the decompression. And the beauty of it is I've got the best possible fixation for her. The facet joints from behind are still intact. So what I do is just decorticate all the facet joints. I get into the joint with a burr and a curette and just lay facet on facet on facet and get her to fuse that way. And she didn't need anything else from in front. And here's her post-op CT scan showing the position of all those screws. And then here's her, the most important thing. We're not treating CTs or MRs, we're treating the patient. You can see her VAS scores at 9 months improved considerably. Her NDI scores improved considerably. Her myelopathy improved. She's a much happier person. So in our first study on this, we concluded that the cervical pedicle screws were feasible. The medial breaches did not cause any significant clinical issues analogous to sublaminar wires or hooks in the epidural space. And we've subsequently added to the case series, and this was published a couple years ago, looking at the feasibility of this. So this is something that we can now do. It's something that you still need to understand the basic anatomy. You understand where you are. You have to understand the limitations of the tools that you're using for this. But here's the next level. This is going even further with this type of technology. And this is a 58-year young female, severe back, neck, difficulty walking, difficulty with her daily activities. Neurological exam wasn't too bad, but here's her surgical history. And you can see it started in 2009 with an L4 to S1 fusion, then cervical, then T2 to the pelvis, then extensions, then revisions, then wound dehiscence, then multiple INDs. And then she comes to the Texas Back Institute to see me in March of 2021. with these x-rays. And you look at this and you go, oh, there's no way we can fix this. This is Humpty Dumpty. You just can't put it back together again. But we do have the ability now. And then this is her CT scan, and you can see the extent of the deformity. You can see her screws here, and she's just fallen off over the top. So this was my plan A for her. Stage 1 was posterior Smith-Peak type osteotomies with halo traction to see what kind of correction I can get. Stage 2, some kind of posterior instrumentation infusion and a possible pedicle subtraction osteotomy to get her head back over her shoulders. And then maybe even a stage 3, I may have to go from in front. And you just plan this out so you're always taking one step forward without limiting your ability to retreat, but still move ahead on this. So here she is in the operating room. You can see the extent of the deformity. This is before we did any of the osteotomies. This was the first stage for her. Here she is in the OR, and you can see the multiple osteotomies that we've created. You can see the top of her old hardware down here, which was surprisingly still intact. I thought this would be loose, and I've exposed up above on there. Here she is in traction, and you can already see with just the traction, we're able to get her corrected quite a bit. She was in traction for about 10 days. She absolutely hated me for the traction. It's torture. There's no doubt about it, but there's no shortcuts to this. And that's what I kept telling her. And here we are bringing her back, setting up the robot, getting everything going. And again, the pre-op plan with everything laid out, ready to go. Here she is intra-op, screws in place, locked her to her previous hardware. I did take out 2 of the screws that she did have in there. So I had an end of rod to attach to. And then here she is now. So much improved, but not the ideal, but better than she was before. And she's quite pleased with it. And here you can see the before and after what we were able to do for her. So, and here's her radiographically. So now she can actually eat, she can communicate, she can interact with the environment, and she's pretty pleased. There's really only one paper in the literature that I could find up to now looking at the accuracy of the cervical pedicle screw placement with respect to direct placement versus computer-based navigation or robotics. And really what was interesting, they had one breach in the navigation, but again, it was not a substantial breach in that, and they felt that everything was quite fine with it, and just more proof that it is a viable option for what we do. So before I go on and talk about Uganda, any questions about cervical pedicle screws or the robotics or the navigation? Any comments? Am I a lunatic doing this? That's fine. If you guys think I am, I can accept that.
Sorry, just a quick question. One thing that we didn't talk about yesterday was the patient's experience or acceptance of the technology. Because I know in general, depending on the population of patient, they may be apprehensive to spine surgery in general because of misunderstandings and different perspectives. So now you're kind of telling them or showing them that you're there, but a quote unquote robot is doing the surgery, which isn't true, but that could become the perception.
So yeah, you do have to absolutely explain that to the patients, that the robot is not doing the surgery. It's a tool. It's just another tool that facilitates me being more precise and more efficient. I get a lot of patients that come to me that say, oh, you're going to do this robotic. I go, no, you know what? This doesn't quite need the robot. It's not the right tool for what you have. So you just have to talk to patients and explain to them that we're going to use the right tools at the right time for the right reason, and address their expectations.
Hi, Izzy, it's Shane. I don't know if you can hear me.
Is that you, Shane?
Yeah, sorry I'm not there in
Hey.
person, but great case discussions this morning and great talk. We published our series on cervical pedicle screws a few years ago. And, one of the things when you're doing that is, you're the kind of at the frontier of this new technology. And can you talk about sort of the concern or fear that you might have, making a mistake, pushing the envelope?
There are those that are the early adopters and see the opportunity, and really you just have to be thoughtful about it. If you look through the history of orthopedics, sublaminar wires were used in the 1900s, early 1900s. Yeah, the first guy that did it thought about it and thought carefully what needed to be done. Look at the first total knee, total hip. There's always that risk, but if you are patient with it, if you think about things, if you practice ahead of time, we did a number of these screws in the lab before we did the first one in a patient. You go through those steps and you think about the patient as if it was yourself or your family member. Am I ready to do this? Would I accept this knowing what I know in my neck? And until you get to that point, you shouldn't be doing it. But individuals like yourself, myself, a number of other colleagues that are the early adopters are putting the time and effort into it. So I don't see that as a substantial limitation. I don't think that's a reason to not do something, because you've vetted it out. You've gone through all of that. Did I answer that well enough, Shane?
Yeah, absolutely. I mean, it's, you put in 10,000 other screws before you sort of go on to the next level. But, there's always that concern or sort of that ethical dilemma of like, okay, I'm the first person to do this, or one of the first people to do this. And what happens if it goes wrong? And how do you sort of justify taking the next step? But I fully agree that it's not like you don't just leap there. It's based on layers and layers of experience. So.
Yeah, exactly. Well, good. Let's move on to the Uganda mission. And I know, Shane, this is something that's near and dear to you as well. This is something that, quite frankly, changed my life, and I'm going to tell a little bit of the story as we go on to it. Unfortunately, the pandemic had tremendous effects on all of us, and I've not been back to Uganda since 2019. And when you see some of the pictures of some of my patients, you'll realize it hurts right here. It really, it's just, I miss it. It's part of my life that kind of disappeared over the last few years. So we're trying to get things going for this year, although Uganda had the Ebola epidemic sort of through last year as well, which shut things down. But what I'm going to go through is providing care in Uganda then and now, where we started way back in 2006 and where we are today. Now, why is my mouse not working? We'll go manual. So Uganda is one of the East African countries. It's landlocked. It's surrounded by Kenya, Tanzania, Sudan, the Republic of Congo. It sits right on Lake Victoria. That's the source of the Nile. It's an absolutely beautiful, beautiful country, and I'll show you some of the geography. It was established as a British Crown colony and gained its independence in 1962. It was ruled, and you may recognize the name, by Idi Amin from 71 to 79. He was a ruthless dictator. He was overthrown by Milton Obote, who was sort of the meant to be the savior of democracy there, but then he became a ruthless dictator. And now Yoweri Museveni is the president of the country. He took power in 1986 as well by overthrowing Obote. And Museveni created a constitution for the country. And the initial constitution said the president will only serve 2 terms. Halfway into his second term, he changed it to 3 terms. Halfway into that, it was 4 terms, 5 terms. He's now in his 6th term as president of the country. But to his credit, compared to the other East African nations, Uganda has been pretty stable. It's not perfect, but it's been pretty stable at this point. The population is about 40 million, and there's some staggering statistics. 1% of the population, there are all these different, 18 different distinct ethnic groups there. But you look at the life expectancy, male is 52 years. So just looking through the room, about a third of us, if we lived in Uganda, we'd probably be dead by now. And that's just amazing when you think about it. 40% of the people that live there only make about $1.25 a day. The birth rate there is 47 per 1,000, compared to the US about 14 1,000. Death rate 12 per 1,000, 8 per 1,000. But here's another one of these staggering statistics. Infant mortality is 86 per 1,000 versus 6.6. And we all know HIV is a big issue there. I don't believe these numbers, because all these little villages are dotted across the country. There's really no good way to census the population and see what's going on there. This is downtown Kampala, a busy metropolis. This is one of the big cities, crowded. These are considered luxury apartments in downtown Kampala. This is on the outskirts of Kampala. This is one of the shanty towns, and people live in these metal huts, and they have storefronts in front and they live behind. And this is what their backyards look like. And you can imagine telling your children, oh, go play in the backyard, and you see what's going on back there. It really is a contrast of extremes compared to what we are used to here. But this is what the rest of Uganda looks like, and it's absolutely beautiful. I sort of make the example, it's like the Colorado of Africa. Beautiful mountains. It sits between 5,000 and 7,000 foot elevation. The temperature never really goes below 75 degrees or above 85 degrees. They have two short rainy seasons, May and September, but it's very fertile. It's the fruits and vegetables that they grow there are the most succulent and tasty that you'll see or taste anywhere. And these are the markets that you have there. It's pretty much a barter economy. Someone will come to the market here and get some tomatoes for a chicken. That's how they live and work there in the majority. And when I got to Texas, I thought I knew Longhorns, but these guys are just roaming around the streets there all day. And what's really interesting is they're pretty smart animals. They know where to go home at the end of the day. It's like they just find their way back home. Now, this is Dr. Mark Kayanja. And Mark is a close friend, a colleague. I consider him my brother. He showed up at my office at the Cleveland Clinic one evening late at night. This was in 2000. And I remember my secretary coming in and saying, there's a Dr. Kayanja here to see you. And I was pretty rude and abrupt, and I was busy that day. And I remember, why am I being such a jerk? But I said, who is he? What is he doing? Can't you see I'm busy? Tell him to go away. She comes back in 10 minutes later and she says, he's not going away. He wants to talk to you. And all right, just bring him in. So the minute I met Mark, I realized, one, he's smarter than I am. Two, he's very articulate. And three, he had a plan. So he's telling me that he was sent to me by Norgrove Penny. Norgrove Penny is a very famous Canadian orthopedic surgeon who left his position in British Columbia to open up the medical school in Uganda. And Mark was the first graduate from Norgrove's orthopedic program at the time. And he said, Norgrove Penny sent me to see you to learn spine surgery. Now, I had no idea Norgrove Penny even knew who I was. But as soon as Mark mentioned the name, I said, okay, I better listen to this guy. So I said, well, Mark, do you have a visa to work here? Do you have a license? Do you have funding? He says, I have nothing. I go, well, I don't know that I can help you. He says, well, I'll work for free. So, well, if you say that, I'm going to put you to work. And he said, yeah, I'll work for free. So we put him to work at the Cleveland Clinic, and within 6 months, he got all his paperwork done. Within 3 years, he got his PhD completed. Within 6 years, he got through the orthopedic residency program at the Cleveland Clinic so he could get his US credentials. 2 days after I met him in the office, I got a registered letter from Norgrove Penny that I still have. Dear Izzy, please take care of Mark. He's one of my prized pupils. He's going to be great. Go for it. And I thought, wow. From the day I met him for about 2 years, every day it was incessant. Let's go to Uganda. Let's go to Uganda. Let's go to Uganda. Let's see Uganda. And Mark was just persistent with it. And I told him, sort of facetiously, I said, Mark, in April of 2006, we'll go to Uganda. This was in 2002. And it was radio silent for 4 years. April 1, 2006, he comes into my office with a stack of x-rays, hotel reservations, flight reservations, patient lists, and he plots on it and says, we're leaving next week. We're going to, I go, what are you talking about, Mark? He says, well, you said April 2006, we're going to Uganda. I said, Mark, I didn't think you'd still be here in April 2006. And that's how it all started. And I've been there every year, at least once, some years twice, because of that gentleman. Now, those are Mark's surgical shoes in one of the hospitals in Uganda. And Mark's obviously come back and forth with us many, many times, and he still goes back. The second trip we went there, we went to work at one of the remote hospitals, and one of the nurses was so excited to see Dr. Mark again. And she saved his boots for him, and she brought them out and said, here are your surgical boots. So that's just the type of guy that he is. And he's really what changed my life and got me involved in this, because I never thought that I would do anything like this. Now, anytime you embark on something like this, there's these stages. And what's great about this trip is I've had over 150 volunteers now join me there. And I ask every one of them at the end of the trip to write an epilogue. And this is all on our website, every single one of those. And if you read through them, it's all the same. There's the excitement about going. Then there's the anxiety when you take off. Then when you land, there's the intimidation. Then as you're working these long days in the most treacherous of environments that you just couldn't imagine, there's the doubt, am I doing what I should be doing here? And then halfway through it, you get homesick. Yeah, I want my Tempur-Pedic mattress. I want my 3-car garage. And then when it's time to leave, you get this remorse. It's like, my God, why am I leaving? There's so many more things that we should be doing here. And as you see the patients that are there, there's this gratification, but there's this guilt. Why was I born into this society? And so many other people are struggling like that. And everyone goes through it. So these are the teams. This was the first team in 2006. There's Mark. That's actually my daughter. All 3 of my kids have come twice now. One's come 3 times. My wife has come as well, and we've gone on from there. This was the 2007 team. You'll see the teams keep growing every year. 2009 was the first year we had 2 teams. 2010 growing. Now 2011, we're official. We got shirts now. We're big time. We're getting there. 2012, 2013, 14, 15, 16, every year, and just more and more and more people coming through it. So it was really, really a great experience in going through all of this with all these individuals. Now, this is the Malago Hospital in 2006. And I don't know if anyone's seen the movie, The Last King of Scotland with Forrest Whitaker. If you haven't, see it. It's a very, very good movie. But Idi Amin was, quote, the last king of Scotland. He built this hospital, the Malago Hospital. It was supposed to be the hospital for all of East Africa. So this is what it looked like in 2006. This is the inside of it. People just everywhere. It's not at all accommodating. This is what the ward looked like in 2006. Let me go back one there. That's what the wards looked like in 2006 when we got there. Some of the buildings were old horse stables. Literally, there's bats hanging from the ceiling. There's only, if you look closely, there's only one sink on this side, one sink on this side. There's no distinction, male, female, adult, pediatric in here. This is right across the road from the hospital, Mumu's Coffin Shop. People die there. The family walks across the road. They buy a coffin. They come back. They put the body in, and they go bury it. This is 2006. That's Mumu himself. But look at the difference. 2013, Mumu's got competition. There's other coffin makers there now. The population is growing. We also operated at a place called Imbarara. This is actually Mark's hometown, and there was a small cottage hospital there. This was the road to Imbarara. This was a life-threatening experience driving there. Potted roads, muds, animals, people. There's no lanes here. People are just driving where they want. We stopped going to Imbarara because of that experience and just concentrated in Mulago. But then in 2013, everyone said, you know, there's a new road to Imbarara. Let's go back down there. And this is the new road to Imbarara. And again, progress was made. So it sort of helped us. But you can see there's still no lanes. People just drive wherever they want. And this is what you're up against. You've got these cattle trucks with people hanging off. Can you imagine seeing this on a California highway? This just wouldn't happen. But these things travel down the highway at 70, 80 miles an hour. They take a curve too sharply. And you can imagine the carnage that you see now that's going on with that. Now, this was the Imbarara Hospital when we first got there in 2006, a little cottage type hospital. This was actually the operating room theaters that were there. This is the hospital in 2013. The government built a brand new hospital there, and we were quite shocked to see it. Beautiful, beautiful structure. But one of the limitations there, and we talked about this at the conference, was the maintenance. They just don't maintain things. They don't upkeep things very well. But this is what it looked like when it first opened up. And then here is the Barara Hospital, the referral center. This is part of the old hospital there. But they say, you know, all services, medical supplies are free of charge there. But here again is a picture of the ward in 2006 at Imbarara. And here it is at 2013. So you can see much better, upgraded bed, but still everyone's all crowded together and you've got teaching rounds. Here's the ward in 2014. Shout out to Shane. Remember this one, Shane? But here is the 2015. And you can see what happens. Things just get overwhelming there. If you look closely, broken femur, there's someone underneath this bed here laying down there, also in traction, all sorts of things. And you just put patients wherever you can. It really is a free-for-all. This was the operating room when we got there in 2006. This was the operating room in the new hospital. This operating room is 1,500 square feet. What a waste. They didn't design it properly. But it's a huge operating room with one little air conditioner there. But now we've been able to outfit it. We've got all sorts of equipment. This was the ICU in 2006 when we got there. This is one little kid with TB that I operated on. And this was an unfortunate individual dying of AIDS. Now, if you follow this oxygen tubing closely, you'll see it connects to a Y connector here that goes to my patient over there. Now, again, this is not something you'd see here, but this is how things were done there. When we got back in 2013, this is the new ICU, and I was just shocked. It was beautiful. They had all the monitors. By the way, this is the same patient from the other slide. No, just kidding. But they had all the new monitors and everything. And over the years from 2013 to last time, 2019, things just started to deteriorate again. And we're planning to go back in 2023, and I'm really worried what the condition's going to be like. Now, this is our anesthetic machine here, but I want to point out the C-arm in the back here. This was the C-arm in 2006 that we had there, and it was functional. Unfortunately, one of the cleaners put a bucket of water on the C-arm, spilled the bucket of water, fried the internal electronics. So for a number of years, we didn't have a C-arm. When we got back there in 2013, we found it. It's sitting back there, way at the back. But we also organized to have a new C-arm delivered. And this was one of the things that we were able to procure. And this is one of my close friends, Rob Davis, who's a Synthase. Now he's a regional manager, but at the time he was one of the implant reps who functioned as the X-ray tech. And he physically built this, put this thing together according to the manual while we were there to get it going. Now, some things do change, but some things don't. This is the clinic in 2006, and people traveled for days to come see us. And here's the clinic in 2013. It's just packed, the overwhelming pathology that shows up. The other thing that happens, and you really don't see our shows, but power failures. This is us operating with a couple little headlamps and someone holding their iPhone up because the power went out in the middle of an operation. And this happens regularly when we're there. And here's at the back, and you can see the waste, the bio waste that's out there. And unfortunately, little kids are rummaging through this looking for old scalpel blades and needles that they can salvage so that their mother can use them to cut meat or whatever it is. And it's just a terrible existence. But this is the type of pathology we see. The mission started as a pediatric scoli TB spine type mission, but very quickly, the last few years, it became a trauma mission because of the Chinese influence in East Africa with all the building and the lack of workplace regulations and using the local Ugandans as the workforce, who then fall off cranes and get crushed by bulldozers. And so it's become a trauma mission. But this is the type of stuff that we will take care of. This is Anthony Owusu. He's one of our fellows at Texas Back Institute who came with us on one of the missions. And you can just imagine how intimidated this kid is when this larger than life human being is doing an examination on him, trying to get it. So it takes a lot to get used to for their part and for our part on it. But these are just some of the OR pictures. And every year that went by, we collected more and more equipment. And we had to figure out a way to overcome the maintenance issue. So we've rented a warehouse there, and all our equipment, when we're not there, is stored in the warehouse. We keep it under lock and key. When we get back, we clean it. We do whatever upgrades we need. Every year, multiple companies, J&J Synthase, Medtronic, and Globus have all been very generous in supplying me with instruments that all stay there. So every year, we just bring implants with us in our suitcase for what we may need. This is 2008. This is when we were getting there, and education is clearly a huge portion of this mission. And we spend time teaching, but here we are. And this was the last time we were there. I'm really proud of this picture. This was 2019 at the medical school. We gave multiple lectures on spine care, myself, Mike Heisey, a couple of the other guys that were there, and the whole campus showed up. And it was really gratifying to see how we're able to help them over time. And these are just some of the other great stories. This was an unfortunate young gentleman who came off his motorcycle, fractured dislocation, paralyzed. Essentially, he was doomed to die. These patients, if we're not there, they're just in bed until they develop bed sores and die. We put them back together, get them reduced. This is Michelle White. She's a physical therapist who's been with us for many, many years. He's actually from Australia. And I'm always impressed at how many good people there really are on this planet, despite all the grief we hear on the media and see on social media type things. But Michelle went about procuring wheelchairs, and hundreds of wheelchairs that she gets to Uganda for our patients to use and anyone else to use. This is Joshua. This is one of my very favorite patients. Namesake. My son's also named Josh, and my son's also an artist, a cartoonist. He works in LA. Has done many movies, Kung Fu Dragon or Kung Fu Panda and How to Train Your Dragon. He was one of the animators on those. But this was Josh with TB of the spine, and this just shows how we have to be creative in what we're doing. Here you can see the abscess coming to the skin. He had a thoracoabdominal approach followed by a posterior approach. But one thing that we didn't bring with us was a rod cutter. So in the middle of surgery, the rod's too wrong. So I had to get someone, run out to the local hardware store, get a hacksaw blade. We sterilized the hacksaw blade, and here I am cutting off the tip of the rod because it was just too long for Joshua's back. But here's the reconstruction that we were able to do being there. And then this is Joshua. There we go. And he was paraparetic before surgery. And this is the first day after, and we're getting him to move
You
his
can
leg.
just ask him to wiggle his toes again.
And as soon as you see this, that's what makes it all worthwhile. I've seen Josh every year since I've gone back there, and he's doing great. He's a young man now working. You don't have incentive spirometers, so again. So you have to be creative. So we give the kids gloves to blow up to keep their chests going. This is the type of stuff that you have to do. And these are my kids. These are the kids that I've seen year after year. And there's we've done over 300 surgeries there now over the years, and most of them come back. A few, I don't know what's happened to them, but this is what gets me back there, and this is what I miss. This is what I consider my family. Now, this is the part of the gratification. This is Stella. Stella was 89 years young when I met her. She had severe spinal stenosis, 1 level at L4-5. I said, yeah, I can fix it. All you need is a decompression. So I fix her, and she does great. She's walking around the ward. She's wonderful. We're there for about a 3-week period. 2 weeks into it, I say, Stella, you can go back to the village. You don't have to stay in the hospital now. She looks at me, she goes, no, I like it here, because here my family comes visit me. When I'm in the village, nobody comes visits me. So I'm just going to stay here. And I don't know how long she stayed, but she was there for a good long time. She did not want to leave. But here's the guilt. This is a 24-year young male, complex cervical spine fracture dislocation, just waiting in bed to die. Pressure sores, severe pulmonary compromise, and you can't save everybody, but you try as much as you can. So the pathology is relentless. The surgery is challenging. The environment is motivating. The patients are remarkable. And the colleagues that we work with there are just inspiring. This is what we've been able to accomplish from 2006 to 2019. And this is what I think is a fascinating number. The total trip budgets over all those years was $1,100,000. We raise about $150,000 a year that essentially covers all of that. So you can think that's probably 2 spine surgeries here in the US right now. And we were able to take care of over 300 people. And we've got plenty of donations coming, but this is the need. Half of the world's population does not have access to healthcare right now. 40% of the world's population do not have access to fresh water. Think about that. They can't go turn a faucet on. It's just crazy when you think of these kinds of numbers that are out there. But these are the issues. Corruption in the third world is still rampant. And we've experienced that multiple times when we were there, with people stealing our medications, stealing our equipment, and extorting from us money to be able to take care of people. And these are some of the things, and there's signs all over that they do want quality health care. This is an interesting sign that's up in the Malago Hospital in one of the vestibules there. Free circumcision services available with support of the United States government. I don't know how someone lobbied for that or what it costs, but I found that pretty interesting. But this is actually also very surprising that no matter where you are in the world, the Dallas Cowboys rule. It's like they're there. They're everywhere. It's just like Coca-Cola. And this is another one of the touching stories just to end off with. This is Aaron, who's a pastor, teacher, and farmer in Uganda. And I met him in 2007. He had a cervical myelopathy, and I took care of his neck, and he came back every year. And he invited me to his home and invited me to his farm. And every year I'd say, yeah, we're busy this next year. And we never actually got to his place until 2019. And I was feeling so guilty. I said, team, we're packing up. We're going to go visit Aaron. And it was one of the most spectacular experiences of our lives. His family put on this spread. They invited half their village. It was just wonderful to interact with people and to see how other people live. So I encourage everybody on behalf of the Uganda patients, just participate, get involved in any way, because there's so much that you can do out there. So with that, thank you for your attention. If there are any questions, I'd be happy to answer them.
Great. Thanks, Dr. Lieberman. I think that was an impressive spread between robotics and international work. And we could open it up for any questions from the audience. Dr. Vale.
Get it started while people are thinking. I'm sure there are a lot of questions. The juxtaposition of technology and working without technology was pretty stark. As you may be aware, there's an Institute for Global Orthopedic Trauma here at UCSF, and a broad interest from faculty and trainees and being involved in international care. And you alluded to the education piece of your mission, and I'm wondering what happens in between visits, and have you, over the years, developed any traction, any continuity between visits, things that happen, programs that are developed that are sustained?
Yeah, absolutely. When we first got there were really only 2 individuals doing any kind of spine surgery in the country. And they were both at the Mulago Hospital, and we started working with them. And at the time when we first got there, they were at the skill level of probably a second-year resident in terms of spine surgery, what they could do and understand. Over the years, now there's probably about 20 individuals, and we're not the only spine mission that goes to Uganda. There's a great mission out of Duke as well. I don't know if you know Hogland and Armstrong that go out there. There's also a couple other European groups that come out there. So amongst all of us, we kind of loosely communicate with each other, but the infrastructure has definitely grown. I brought 3 individuals from Uganda over. One was to the Cleveland Clinic, the other 2 were Texas Back Institute that have come, trained, done observerships, and gone back, and they're kind of the nidus. I still get x-rays and follow-up from a lot of my patients, especially that we've not been there. We've trained a couple PAs that run remote spine clinics and kind of triage patients. So slowly and steadily, it has built up. And it doesn't happen overnight, and you just have to be persistent with it.
Great, thank you.
Hey, Dr. Lieberman. We met briefly yesterday, and I know we're running out of time, so I'll make this brief. But I had one of the third-year residents, and I had a quick question for you. Just wondering, a lot of us had done global health work, and we have a whole institute here dedicated to that. And it seems like there's a lot of different actors kind of working towards the same goals, but often in isolation. Like when I was in Tanzania, I met maybe 9 or 10 different surgical teams coming from different countries, kind of trying to do the same thing, but without realizing that different people were there kind of working on that same philosophy. And I wonder if you had any thoughts on how we can better coordinate care among these different actors, or how we can create a more unified approach so that people aren't duplicating, but more, progressing and building on what's been done before.
So part of it is communication, knowing who those individuals are and communicating with them. And that's what we do with some of the groups in Europe, and with the group from Duke. I don't know if you guys know Tiffany Perry at Cedars-Sinai. She came on a couple missions with me, and now she's running her own mission in Uganda. And between her and I, we communicate back and forth. She's going in April. I'll go in July, and we try to set things up. There are a couple other different entities. One group that's come up, but the efforts were a little hampered by the pandemic, is a group called On Belay that is trying to do exactly what you're suggesting, is bring all these groups together and organize them. Our mission is affiliated with Health Volunteers Overseas, which is a philanthropic organization based in Washington. Came out of the American Academy of Orthopaedic Surgeons. It started as purely orthopedic mission, but now it's health volunteers. So they've got all the disciplines represented. They're the 501c group that I use for fundraising, so that I don't have to worry about all the tax issues and writing different grants and things like that. So the Health Volunteers Overseas does all that work for us, but they also coordinate amongst multiple groups, and we look for economies of scale. A couple years, I would ship a container over, and they know that I'm shipping a container of equipment over. They ask me, do you have room for dental equipment? Do you have room for other stuff? So we try to get that all coordinated. It's just persistence and effort. That's what you just need, persistence and effort. But look for On Belay, Health Volunteers Overseas. North American Spine Society does have a group. SRS has their global outreach program. I was on the committee and worked with them for a number of years. There's a lot of good people there. Just get yourself involved and start communicating with them, and that's how you'll coordinate care amongst all the different programs.
Well, Lizzie, I think we're going to wrap it up with that. Thanks so much for being our visiting professor on behalf of the Spine Pod and our department. You've done a lot in the last 2 days. The Journal Club last night, dinner with chief residents, and this morning. There's still one more task. We'll move on to just having some discussion with the residents from here. But and there's also some messages for you on the online audience that you had. So I'll share those with you. I collected those. So
awesome.
But thanks for being with us this morning.
The pleasure and privilege is mine. Thank you all, and I look forward to more interaction.